All right, welcome everyone. Today we're going to take a deep dive into the incredibly intricate anatomy of the female reproductive system. Now, if you're in the medical field, this is definitely for you. We're going way beyond the basics to really explore the detailed morphology, the complex neurovasculature, and those crucial spatial relationships that are just so vital for clinical practice.
Okay, first things first, let's get our bearings. This view really shows you just how crowded the neighborhood is inside the pelvic cavity. I mean, look at how close these three major systems are to each other. You've got the urinary system up front with the bladder, then the gastrointestinal system in the back with the rectum, and boom, sandwiched straight in the middle is the reproductive system. This arrangement is so clinically important because a problem in one of these systems can easily and directly affect the others.
So here's our game plan for this tour. We're going to start big picture with the pelvis itself, then zoom way in on the ovaries. After that, we'll follow the path an oocyte takes, check out the support system holding everything in place, and finally map out all the nerves and blood vessels that make the whole thing work.
Okay, let's kick things off with Section 1. Before we can really appreciate the organs, we have to understand the space they live in, the pelvis.
So, what exactly are we looking at? Well, the pelvic cavity, or what anatomists call the true pelvis, is basically everything sitting below the pelvic brim. The best way to think about it is as a protective, bony, and muscular bowl that houses all these vital organs. Everything we're going to talk about today happens right inside this space.
Now, let's zoom in on the primary female gonads. These are the functional powerhouses of the entire system, the ovaries.
In terms of their shape or morphology, they're usually described as being about the size and shape of an almond. And what do? Well, they've got two main jobs. First is oogenesis. That's the development of the female gametes, the oocytes. And second is sterogenesis, the production of those absolutely essential reproductive hormones.
And here, you can see exactly where the ovary sits. It's not just floating around in there. It's securely anchored to the pelvic wall by the suspensory ligament of the ovary. And check this out. That ligament is basically the superhighway for all the ovarian blood vessels. It's also tethered to the uterus medially by the ovarian ligament.
Now, if we could just slice an ovary open and take a look inside, we'd find three distinct layers. On the very outside surface, you have what's called the germinal epithelium. Just beneath that is the cortex, and this is where all the action happens. It's packed with all the ovarian follicles in their different stages of development. And then, deep in the core is the medulla, which is basically the main entry and exit point for the blood vessels and nerves.
Okay, this is really cool. The ovary's blood supply is fascinating because it's not a one-trick pony. It has a dual supply. The main pipeline is the ovarian artery, for sure, but it also gets a major boost from branches of the uterine artery. This connection, this anastomosis, creates an incredibly resilient blood flow.
But, and this is a big but, this backup system comes with a huge clinical warning. As this quote points out, the exact way these arteries connect is highly variable from person to person. For a surgeon, not appreciating that variability can lead to disaster, like uncontrolled bleeding during a procedure. So understanding this anatomy isn't just an academic exercise, it's absolutely critical for patient safety.
So here's the bottom line, the thing you absolutely have to remember. These two arteries come from completely different places. The ovarian artery branches directly off the abdominal aorta, way up high near the kidneys. The uterine artery, on the other hand, comes from way down in the pelvis as a branch of the internal iliac artery. Totally different origins.
All right, on to our next section. Let's follow the journey. Imagine you're an oocyte that's just been released from the ovary during ovulation. Where do you go next? Let's trace that path through the female genital tract. So the journey kicks off at the uterine tubes, which you probably also know as the fallopian tubes. And what's wild is that they aren't actually glued to the ovary. Instead, they just kind of drape over it, creating this little space for the oocyte to get scooped up after it's released.
Now, the uterine tube isn't just a simple pipe. It has four very distinct parts, and each one has a special job. First, you've got the fimbria. These are these amazing finger-like projections that are actively sweeping the ovary to catch the oocyte. They guide it into the funnel-shaped infundibulum. From there, the oocyte travels into the ampulla. This is the widest part, and it's the usual spot where fertilization happens. And finally, it passes through the narrow little isthmus to get into the uterus. And that path leads us right to the main event, the uterus. It's a thick-walled, pear-shaped muscular powerhouse designed for implantation and fetal development. This view gives us a great look at its internal cavity and how it connects to the tubes up top and the vagina down below.
We can break the uterus down into a few key regions. Think of it like a tour from top to bottom. At the very top, that dome-shaped part above where the tubes enter, that's the fundus. The main central part is the body. And that narrow, lower part that pokes into the vagina, that's the cervix. The pathway through the cervix has two gates, the internal os on the uterine side and the external os on the vaginal side.
So now that we've met all the main players, what actually holds them all in place? Let's take a look at the intricate network of tissues that keeps these organs right where they're supposed to be.
This support system is absolutely 100% vital. It's this combination of muscles, thickened connective tissue called fascia, and folds of the pelvic lining. And when this system fails, well, that's when you can run into serious clinical problems like pelvic organ prolapse. So having a solid grasp of this is key.
This view right here is just perfect for seeing what I'm talking about. You can see how the uterus and cervix are anchored from the sides by these thick bands of fascia. Now, it's important to note when we say ligaments here, we're not talking about the kind that connect bone to bone, but they are incredibly important for preventing the uterus from descending.
So here's a quick cheat sheet of the big ones. The broad ligament is kind of like a big sheet draped over the uterus. But the real workhorses, the active supports, are the transverse cervical or cardinal ligaments, holding things steady from the sides, and the uterosacral ligaments, pulling the cervix back towards the sacrum. The round ligament is a bit different. It helps keep the uterus tilted forward.
All right, last but definitely not least, let's get into the wiring in the plumbing. This is the complex neurovasculature that allows these organs to function, respond to hormones, and of course, sustain a pregnancy.
The whole control system is autonomic, which just means it's all involuntary, and it's a dual input system. You've got sympathetic nerves coming from the T10 to L2 spinal levels, which generally cause uterine contraction and tighten up blood vessels, and then you have the parasympathetic nerves from the S2 to S4 levels, which are thought to do the opposite, relax the uterine wall and open up blood vessels.
Okay, buckle up, because tracing this sympathetic pathway shows you just how intricate this whole setup is. The signals don't just take a direct flight from the spine to the uterus. No way. They travel through a series of nerves, stop at junctions called ganglia, and then the final nerve fibers have to navigate through this whole web of nerve plexuses before they finally reach the wall of the uterus. It's a really complex journey.
And that brings our anatomical tour to a close. We've traced the intricate relationships, that tricky and variable blood supply, and the complex support systems. And it all kind of leads to this question, right? In an area of the body this complex, where variability is pretty much the rule, how can we use technology to better help surgeons navigate these structures and ultimately make procedures safer for patients? It's definitely something to think about. Thanks so much for joining me.